Welcome back to the deep dive. We're jumping into some really important notes today, based on a key textbook chapter for anyone studying pediatric nursing.
That's right. We're focusing on pediatric endocrine disorders.
Exactly. It's a complex area. Sometimes the signs are, pretty subtle in kids.
Yeah, the endocrine system, it's like this finely tuned orchestra in children, controlling growth, metabolism, development, lots of critical stuff. And if one hormone is off, it can affect everything. Spotting it early is key.
And that's really our goal here. We want to unpack these notes for you, pull out the most important bits, the pathophysiology, what signs and symptoms you absolutely need to look for, the treatments, including the specific meds listed here, and crucially, the nursing care.
Right, because your assessment, your astute nursing assessment, that's often the first line of defense in catching these things.
So let's get a quick overview. The notes cover the big players. The pituitary gland, both anterior and posterior parts, the thyroid and parathyroids, the adrenal glands, the pancreas thinking diabetes here, and the gonads.
And these dysfunctions, they can be congenital, meaning present at birth or acquired later on. And like you said, they often whisper before they shout in kids.
Which makes your observation skills just paramount, noticing that subtle growth delay or maybe unexplained fatigue. That could be the first clue.
Absolutely. It puts you, the nurse, right there in identifying and advocating for these kids.
Okay, let's start with the pituitary, often called the master gland, right? Because it directs so many other hormones.
Exactly. And one major issue the notes highlight is growth hormone, or GH deficiency. This usually comes from hypopituitarism. The pituitary just isn't producing enough GH.
So symptom-wise, the notes point to the obvious, like delayed growth, but also things like immature facial features for their age, being noticeably shorter than peers,
Right.
and diagnostically a delayed bone age on X-ray. That seems important.
Yeah, the bone age X-ray really shows if their skeletal maturation is lagging behind their actual age. Diagnosis also often uses a GH stimulation test, basically seeing how much GH the pituitary releases under stimulus.
And the treatment.
It's replacing what's missing, so recombinant GH injections.
Given daily, usually, until the child hits their final height potential. And for nursing, the notes emphasize that monitoring growth is, like, the primary job.
Totally. Plotting that growth on the chart meticulously tells you if the treatment is actually working. It's your main feedback loop.
Makes sense. Now, the flip side is pituitary hyperfunction, too much GH.
Right. If that happens before the growth plates in the bones close, you get gigantism, extreme linear growth. If that happens after puberty, it's called acromegaly, where the bones thicken, hands, feet, facial features get coarser.
And the notes say this is often due to a tumor, a GH-secreting adenoma.
Usually, yes. So you might see a child just significantly taller than everyone else, or those characteristic features of acromegaly.
Treatment then would be focused on the tumor.
Typically, yes. Surgical removal of the adenoma is common, and sometimes medications are used to suppress GH levels.
Okay. The pituitary also signals the start of puberty. But sometimes that signal comes way too early. That's precocious puberty.
Defined here as puberty starting before age 8 in girls, or before age 9 in boys. It's significantly earlier than typical.
And the notes differentiate between central, which is like true puberty starting from the brain, and peripheral puberty. The main treatment mentioned is a type of medication called GnRH analogs.
Yes, and leuprolide is the example given. These drugs essentially pause puberty. They tell the pituitary to hold off on those signals.
Giving the child time to mature emotionally and socially closer to their peers.
Exactly. And the nursing focus here really shifts, doesn't it? Beyond the medication itself, you're dealing with major psychosocial concerns.
Oh, absolutely. Imagine going through those physical changes years before your friends. Body image issues, feeling different, it's huge. Supporting the child and family emotionally is just as critical as the medical treatment.
Requires a lot of sensitivity.
Okay, moving to the posterior pituitary, its big job involves water balance, right? Through ADH, antidiuretic hormone.
Also called vasopressin, yeah. And when you don't have enough ADH, you get diabetes insipidus, or DI.
Super important point. DI has nothing to do with blood sugar or insulin. It's purely a water problem.
Absolutely. Critical distinction. The pathophysiology is simple. No ADH means the kidneys can't reabsorb water effectively, so water just flows right through.
Leading to the classic signs: polyuria, massive amounts of dilute urine, and polydipsia, intense, constant thirst.
They can become severely dehydrated very quickly. And because they lose so much water relative to salt, they're at high risk for hypernatremia, high sodium levels, which is dangerous.
Diagnosis mentioned includes a water deprivation test, checking serum and urine concentration.
Right, osmolality tests. Treatment involves replacing ADH, usually with desmopressin, DDAVP, which is a synthetic version, plus careful fluid management.
And for nursing, vigilance sounds key.
Oh, completely. Strict intake and output monitoring is non-negotiable. You need precise numbers. And you're constantly assessing for dehydration signs, skin turgor, mucous membranes, fontanelles in infants, and neurological changes indicating that high sodium.
Then there's the opposite problem.
Yeah.
SIADH, syndrome of inappropriate antidiuretic hormone.
Yeah, here the body makes too much ADH, or ADH is working when it shouldn't be. So the kidneys hold on to too much water.
Diluting the body's sodium.
Exactly, leading to hyponatremia, low sodium. Symptoms are kind of the reverse of DI. Low urine output even with normal fluid intake, weight gain from water retention.
And the scary part is the low sodium effects, right?
Yeah.
Altered consciousness, confusion, headaches, even seizures.
Definitely. Management involves strict fluid restriction, which can be really tough for patients. Sometimes carefully administered IV hypertonic saline is needed to raise sodium levels, but that requires intense monitoring.
So again, nursing is crucial. Close neuro checks because of that seizure risk from low sodium and strict INOs, but this time focusing on limiting fluids.
It's a constant balancing act.
Okay, let's shift down to the neck, to the thyroid gland. That butterfly-shaped gland controlling metabolism.
Right, how fast the body burns energy. A really critical one here is congenital hypothyroidism. Thyroid is absent or underdeveloped at birth.
And the signs in newborns can be subtle, can't they? The notes mention things like hypotonia, kind of floppy, prolonged jaundice, a large fontanelle constipation, dry skin.
Yeah, not always obvious,
Right.
which is why newborn metabolic screening is such a lifesaver. Every baby gets screened, usually looking for high TSH, thyroid-stimulating hormone, and low T4, the actual thyroid hormone.
Early detection is vital for brain development, isn't it?
Absolutely crucial. Treatment is straightforward but lifelong. Daily oral levothyroxine, which is synthetic T4.
And the nursing role here sounds heavily focused on parent education.
Huge. You have to explain why this tiny pill every single day for life is essential. How to give it correctly crushed, small amount of liquid, not with soy formula, usually on an empty stomach, and the need for regular blood tests to monitor TSH-T4 and adjust the dose as the child grows. Adherence is everything for their neurological outcome.
Then older kids can get acquired hypothyroidism, often Hashimoto's.
Yes, Hashimoto's thyroiditis is common. It's an autoimmune attack on the thyroid leading to underactivity.
SS are more classic. Fatigue, cold intolerance, maybe some weight gain, and importantly in kids, a slowing of growth velocity. Treatment is the same, right?
Yeah.
Levothyroxine.
Daily levothyroxine, yes.
And the opposite, hyperthyroidism, often Graves' disease.
Graves is the most common cause in kids, another autoimmune issue, but this time antibodies stimulate the thyroid to overproduce hormone.
So these kids are just revved up.
Pretty much. Weight loss, despite a huge appetite, always feeling hot, tachycardia, fast heart rate, maybe a goiter, irritable, sometimes those bulging eyes, exophthalmos.
Treatment aims to slow the thyroid down. The notes mention antithyroid drugs like methimazole.
Right, methimazole is common. Also, beta blockers are often used to control symptoms like the rapid heart rate and tremors while the antithyroid meds kick in. Sometimes surgery thyroidectomy is considered.
Nursing focus, monitoring vitals, especially that heart rate, managing symptoms like heat intolerance, helping the child and family cope with the irritability.
Exactly. It affects their whole life, school included.
Okay, tucked behind the thyroid are the tiny parathyroid glands. Their job is calcium balance.
Calcium and phosphate, yes. Regulated by parathyroid hormone, PTH.
So low PTH means hypoparathyroidism, which leads to low serum calcium, hypocalcemia.
And low calcium makes nerves and muscles really irritable, so you see neuromuscular excitability, muscle cramps, tetany, those involuntary muscle spasms, even seizures. The classic Chvostek and Trousseau signs relate to this.
Treatment seems direct. Replace the calcium.
Oral calcium and vitamin D supplementation. Vitamin D is crucial for calcium absorption.
Nursing means watching carefully for those signs of low calcium and really stressing medication adherence. Missing doses could cause symptoms?
Definitely. Hyperparathyroidism, too much PTH, high calcium is mentioned as rare in children.
But if it happens, symptoms are fatigue, nausea, kidney stones, bone pain. Treatment is usually surgery.
Right. Now let's tackle the adrenal glands. Those little glands on top of the kidneys, they're complex, making cortisol, aldosterone, androgens.
Yeah, and this is where things can get really interconnected. Let's bring in that special expert focus now, particularly on congenital adrenal hyperplasia, CAH. It sounds like one enzyme issue can cause a cascade of problems. Can you break down how that works and why it can be so serious?
Absolutely. CAH is a fascinating, though challenging, example. Most often, it involves a deficiency in an enzyme called 21-hydroxylase. Think of the adrenal gland having different production lines for cortisol, aldosterone, and androgens.
Okay.
21-hydroxylase is needed for the cortisol and aldosterone lines. If it's deficient, those lines get blocked. The raw materials can't become cortisol or aldosterone.
So you end up low on those crucial hormones.
Precisely. And all those precursor chemicals, they get rerouted down the only open path, the androgen production line. So you get too little cortisol and aldosterone and too much androgen.
Wow. So the body's trying to make stress and salt hormones, but pumps out male hormones instead. That explains a lot.
It does. In genetic females, this excess androgen during fetal development can cause ambiguous genitalia at birth, which is obviously a very sensitive issue needing specialized care and support.
A huge challenge for families right from the start.
Definitely. And for both boys and girls, especially with the salt-wasting form where aldosterone is very low, there's a massive risk of an adrenal crisis or salt-wasting crisis.
Yeah.
Without aldosterone, the kidneys just pour out salt and water.
Leading to what exactly?
Severe dehydration, dangerously low blood pressure, hyponatremia, low sodium, and hyperkalemia, high potassium. It is a true medical emergency, life-threatening.
Okay, that is serious. How is it diagnosed?
Often through newborn screening, which checks for high levels of 17-hydroxyprogesterone. That's one of those precursors that builds up when 21-hydroxylase is blocked.
And treatment is lifelong replacement that.
Yes, lifelong hormone replacement therapy. Hydrocortisone replaces cortisol, fludrocortisone replaces aldosterone, and for the salt wasters, they need added salt supplements.
The nursing role here sounds intense, focusing heavily on education.
It's absolutely vital. You're teaching parents meticulous medication administration, dose adjustments for growth. Critically, you're teaching sick day rules, how to increase the hydrocortisone dose, we call it stress dosing, during illness or fever to prevent a crisis, and they need an emergency injection kit and know exactly when and how to use it.
Wow. Empowering families to manage that complexity is key.
It really is. Now, another adrenal issue is Addison disease, primary adrenal insufficiency.
This is where the adrenal glands themselves are damaged, leading to low cortisol and aldosterone production.
Correct. Symptoms often develop more slowly. Weakness, fatigue, weight loss, hypotension, low BP, a craving for salt, and that distinct hyperpigmentation, a tanning or darkening of the skin especially increases. And like CAH, there's always the risk of an Addisonian crisis.
Treatment is lifelong replacement again.
Yes, daily glucocorticoid, hydrocortisone, and mineralocorticoid, fludrocortisone replacement.
And nursing focuses on sounds similar to CAH.
Very similar emphasis. Absolute need for daily medication, never skipping doses, and hammering home the importance of stress dosing during illness, injury, surgery. These meds are life-sustaining.
Okay. Then the opposite, Cushing syndrome. Too much cortisol.
Right. Often in kids, it's from long-term use of high-dose steroid medications for other conditions like asthma or autoimmune diseases. But it can also be a tumor.
And the signs are pretty characteristic, aren't they? The moon face, truncal obesity, that buffalo hump fat pad.
Yeah, purple striae, stretch marks, thin skin, easy bruising, and a major one in kids. Growth suppression. High cortisol stunts growth.
Treatment depends on the cause.
Exactly. If it's a tumor, surgery. If it's medication-induced, a very, very careful, slow taper off the steroids under guidance. You can't stop them abruptly.
Nursing involves watching for those physical signs, monitoring blood pressure, which is often high, and keeping a close eye on that growth chart.
Definitely. Okay, finally, let's talk diabetes mellitus, involving the pancreas, insulin, blood sugar regulation.
Starting with type 1 diabetes, T1DM. This is the autoimmune kind.
Yes. The body's immune system destroys the insulin-producing beta cells in the pancreas. Result, absolute insulin deficiency. Can't make insulin anymore.
And the classic symptoms everyone learns, the polys.
Right. Polyuria, peeing a lot. Polydipsia, very thirsty. Polyphagia, very hungry. Often with unexplained weight loss, fatigue. And sometimes new onset bedwetting in a child who was previously dry is a big clue.
Diagnosis, high blood sugar levels, right?
Yeah.
Fasting glucose over and under 26, or A1C 6.5% or more.
Correct. And management is lifelong intensive.
Requires insulin.
Lifelong insulin therapy, either multiple daily injections or an insulin pump. Plus constant blood glucose monitoring, carb counting for meals to match insulin doses, understanding exercise effects, sick day management. It's a 247 job.
The nursing education component here is just enormous.
Monumental. You're teaching the child and family everything from scratch. Injection technique, pump management, glucose monitoring, carb counting, treating highs and lows, sick days. It requires incredible patience and ongoing support.
And a major complication is DKA, diabetic ketoacidosis.
A true medical emergency. Severe insulin deficiency means the body can't use sugar for fuel, so it breaks down fat, producing ketones, which are acidic.
Leading to high blood sugar, acidosis, severe dehydration.
Exactly. Signs you must recognize. Small respirations, that deep, rapid breathing trying to blow off acid, a fruity smell to the breath from ketones, abdominal pain, vomiting, severe dehydration.
Treatment is hospital-based, 4V fluids, continuous insulin fusion, careful electrolyte correction.
It's intensive care. Nursing involves rapid assessment, very close monitoring of vitals, glucose, electrolytes, especially potassium, and neurological status because of the risk of cerebral edema during treatment.
Okay, and then there's type 2 diabetes, T2DM. We're seeing this more in kids now, right? Linked to obesity.
Increasingly, yes, especially in adolescence. This is primarily insulin resistance. The body's cells don't respond well to insulin, combined with the pancreas eventually struggling to keep up production.
Symptoms can be mild or even absent initially.
Often, yes. Which is why screening in at-risk kids is important. Management starts with lifestyle. Diet and exercise are absolutely foundational.
But medication might be needed.
Yes, the notes mention metformin as a common oral medication if lifestyle changes aren't enough. And sometimes insulin might be needed too, especially initially or if control remains poor.
Nursing focus here is heavily on supporting those lifestyle changes, which can be really challenging for families.
Huge emphasis on education and motivation for sustainable diet and activity habits.
So as we pull this all together, looking back at the notes, some key nursing themes just keep popping up across all these different endocrine disorders.
Definitely. Consistent monitoring of growth and development is one. It's such a sensitive indicator, especially for GH, thyroid, and even Cushing's or poorly controlled diabetes.
And family education. It's central to everything. Explaining the why behind the condition, the medications, the side effects, how to do the monitoring blood glucose, hormone levels.
And those sick day rules. Whether it's adjusting insulin or stress dosing hydrocortisone for CAH or Addison's families, have to know what to do when the child gets sick. It's often life-saving information.
Absolutely. Then there's addressing the psychosocial side. Body image, feeling different, the burden of chronic management. These kids and families need emotional support.
For sure. And practical support, too, like helping with school accommodations. Getting a 504 plan in place for a child with diabetes, for example, ensures they have support for monitoring, insulin, snacks, etc. during the school day.
Makes a huge difference. And finally, emergency preparedness. Making sure families have and know how to use emergency meds like glucagon for severe low blood sugar in T1DM, or that emergency hydrocortisone injection for adrenal crisis.
It's about creating those safety nets.
Wow. Okay, that was a really comprehensive dive. It's clear just how intricate the endocrine system is, especially in kids, and how dysfunction can impact so many aspects of their lives.
It really is. And through it all, the nurse's role is just so multifaceted. From sharp assessment skills to expert care delivery, medication management, monitoring, and crucially, that role of educator and supporter for the family.
Yeah, it really underscores that managing these conditions successfully isn't just about the medications or the lab values. It's about supporting the whole child, the whole family, often for the long term.
It's a true partnership for sure.
So that brings us to a final thought for you to consider as you move forward in your nursing practice. Given that so many of these pediatric endocrine conditions are lifelong, what do you think is the single most important long-term goal you would set when caring for a child and their family dealing with one of these chronic disorders, thinking beyond just making sure they take their medications correctly? What's that bigger picture goal?